Should existing healthcare providers have veto power over doctors and clinics that want to move into a community? How does this impact healthcare choices for local residents? I'm Richard Nelson, your host, and joining us to talk further about certificate of need and a few other topics of interest regarding healthcare policy is Bob Moffit. He's a senior research fellow at the Center for Health and Welfare Policy at the Heritage Foundation. Bob served in the Reagan administration as a senior official of the U.S. Department of Health and Human Services and the Office of Personnel Management. And he currently specializes in healthcare entitlement programs, particularly Medicare and overall reform efforts. Bob, welcome to the Commonwealth Matters.
It's great to be with you, Richard.
Hey, I really appreciate your time. And by the way, as I was looking at your biography, I just hit some of the high points here because we'd be here for another 2 minutes if I covered all of the different areas.
It's not about me, Richard. It's about the issue, right?
Yeah, well, thank you. That's very, very, very kind.
I will mention one other thing, though, that is important for this discussion. I served for 8 years on the Maryland Healthcare Commission, which is one of the most powerful regulatory agencies probably in the country. Dealing with healthcare. I was appointed by Governor Ehrlich, a Republican, and then when Governor Larry Hogan became governor, I was appointed again and I was made chairman of the Maryland Healthcare Commission. And the Maryland Healthcare Commission has broad regulatory authority, but the thing that's important here is it is the major agency that determines certificate of need in the state of Maryland. So this is not merely an academic experience for me. I have been involved directly with certificate of need for 8 years in one of the largest concentrations of hospitals in the East Coast. Maryland has 48 acute care hospitals. But the market, despite the fact there are 48 hospitals, the market in Maryland is very, very concentrated. You basically have giant hospital systems, about four or five of them. So all of these 48 acute care hospitals are basically branch offices of 4 large corporations, and it's a highly uncompetitive market. So, and that's a function of policy, Richard. It's not because the markets don't work. It's because government doesn't work very well when it comes to regulating healthcare.
Bob, thank you for sharing that. And before some of our listeners might be tempted to tune out, I want to encourage them to stay tuned into this program because this is an issue that affects them. Much of Kentucky's rural, far west Kentucky, the mountains of eastern Kentucky, south central, very rural. And we have small hospitals in place in many of these rural counties. And some people might think, well, we got a hospital and everything's okay. But this issue of certificate of need affects every one of us because it deals with offering more choices. It deals with the idea of having options in your local community, pricing. And these are things that affect every one of us. So I invited Bob Moffit to be on the program to talk about this issue. By the way, it was a hot issue this last primary election season here in the Commonwealth, and especially in the northern part of the state, which is a suburb of Cincinnati. You have a couple of large hospital systems there that were very much opposed to certificate of need reform. So Bob, I'm going to start with this just to make sure that I have the right understanding of certificate of need. Of course, the acronym is CON. I don't know if that's the appropriate way to refer this, but CON is short for certificate of need.
I think it is.
Okay, yeah, I thought you might think so. So certificate of need is government intervention in the healthcare industry. And it says that hospital officials or medical providers that want to build, expand, or modify a hospital or medical facility must first prove to a state agency that there is a need for their proposed action. So essentially, certificate of need limits new medical providers and services from entering a community. Is that a fair understanding?
That's a fair understanding. Basically, what certificate of need is, it's basically a permission slip by the government to either construct a new medical facility, modify it, or expand it. And basically, that's the only way that medical professionals, hospital organizations, doctors, clinical groups, group medical practices can actually function is to get this permission slip from a government state agency. In my case, it was the Maryland Healthcare Commission, and I can tell you, there are about 35 states now, plus the District of Columbia, that have certificate of need laws. Most of these are not a product of regulation; these are laws passed by state legislatures. And the way it usually works is that the doctor, the hospital, the doctors, the group of doctors, the hospital organization will come to the agency, and they will have to meet, or they will have to prove that they meet some very specific set of regulatory criteria that will provide expanded coverage or improve the quality of care or whatever for the people in the area. So what this requires, though, is often detailed studies, analyses, various kinds of statistical projections. And what I've noticed in my experience, because I actually used to run the certificate of need operation, is that this ends up with a requirement that the medical professionals hire an army of lawyers, lobbyists, and consultants that have to do the work. The process itself usually involves a very, very heavy staff analysis of what, in fact, the medical professionals are providing, site visits, and, of course, hearings. And in hearings, oftentimes you will have organizations that oppose the creation of a new medical facility or medical expansion or an expansion of an existing facility. And so it's a very, very political process. It can be very time consuming, often taking months, sometimes even years, and sometimes costing hundreds of thousands of dollars in what we would say would be administrative or legal cost or consulting cost, none of which add one red cent to the quality of care being delivered to the citizens of the state. I think it is one of the worst things that undercut the competitiveness of our healthcare system at the state and local level. It's a, you have to go through so much, and I actually had a responsibility, for authorizing a new hospital, and I was the lead guy because it was a very controversial matter, and they wanted to give it to me. For obvious reasons, but it took me 17 months, and I spent almost every weekend, in 2017, 2018, to actually get a certificate of need or approve a certificate of need for the Prince George's Regional Medical Center in Maryland, which is a brand new state-of-the-art hospital. But my goodness, it was really an effort.
17 months of time, energy, and resources to get a new hospital approved. So Bob, I want to go to this. One of the arguments I understand that would justify certificate of need is the claim that certificate of need laws reduce and control healthcare costs. And the theory is that by restricting market entry and expansion, states will reduce their investment in facilities and equipment. I'm not saying I agree with that, but that's the strong argument I think that the state has for having a CON law. Is that fair?
That's a fair statement of what the special interests insist to be true. The professional literature, and I'm familiar with it, does not hold that position at all. I mean, the fact is that as a general rule, states that have certificate of need laws have healthcare costs that are about 11% higher on average than states that do not. There's another large and growing body of professional literature that these laws increase. They don't decrease healthcare costs. And they do not, based on, I'm talking about peer-reviewed academic literature, they do not improve quality, and they do harm competition. I will just mention one other thing. This is not simply, a group of, independent academics out there at Harvard, Yale, Columbia, Princeton, spending time attacking state laws. That's not what's going on here. The Federal Trade Commission and the Department of Justice Antitrust Division under both Democratic and Republican administrations. And we're not talking, I'm talking about Obama and George Bush, right? Donald Trump. They have consistently opposed, when they've been called upon to testify in state legislatures, the Federal Trade Commission and the Department of Justice have consistently opposed the expansion or the continuation of certificate of need laws because they have said that they hinder competition, they're barriers to entry, and they undermine, they're fundamentally anti-competitive, and they limit choice and they stifle innovation in healthcare financing and delivery. In short, they're fundamentally anti-competitive. Now, that is a position held by the Obama team and the Bush team and the Trump team. I mean, when you have that level of consensus, I think the special interests have got a problem. This thing has been driven by money and politics and lobbying at the state level, and hospital organizations at the state level are very powerful. I know. I was on the receiving end of a lot of this. This is, as I said to you, Richard, for me, this is not an academic exercise.
Yeah. Bob, if I could interrupt, we saw the Hospital Association in Kentucky get very involved with primary elections. They donated at least I believe it's $50,000 to a political action committee that supported those candidates that were opposed to certificate of need reforms.
Well, let me tell you how bold some of this is. We had a hearing, and I was chairing the hearing, and I remember we had a group of we were talking about what we did. One of my initiatives was to have some regulatory reform when I was chairman of the commission. We had a hearing one time. I'll never forget it. We had a hearing one time. It was a public hearing, and the organizations, the medical providers who were, I guess, the folks who had the power, in other words, who had the market control, would testify. They would testify. And of course, they would testify against any change. And I remember one, and I thought to myself, my goodness, this is remarkable. I remember one of the witnesses represented the Hospice Association. Okay, right? And, they said that if you eliminated or restricted or cut back or reduced all of the regulatory controls and certificate of need, that this would be bad for our bottom line. They said that in public. So my question to them was, do you think that it is the public responsibility of public officials who are appointed to uphold the laws of the state of Maryland and see to the proper achievement or the proper support of the public interest? Do you think that it's our responsibility to function as agents of your private profitability? Of course, I got dead silence. I said, now I want to say something to you. In any other context, if this were the case, we'd be having a conversation with the FBI.
You put a very fine point on that, didn't you? And very pointed.
You can't hurt our bottom line. And the argument was, if we have other organizations providing the same services, we could lose labor. They could go and work for other people. My goodness. And I was thinking to myself, where's the AFL-CIO on this? What do the labor unions think about this idea? It's bizarre.
Yeah. And of course, the concern should be for more consumer choices, less cost, easier access. These are things that benefit all of the public. And to your point, the public should not be a major point as to impacting the bottom line of a specific industry or business.
Kentucky is at a crossroads. We can choose to give in to the radical left, or we can choose to engage the culture in a God-honoring way.
I started the Commonwealth Policy Center because I believe that Christians have a responsibility to influence government and society to the glory of God. While the Commonwealth Policy Center's made a significant impact, our work isn't finished. If you'd like to join our movement working for timeless values, then head to our website.
To learn more, go to commonwealthpolicycenter.org.
If you're just joining us, I'm Richard Nelson here with the Commonwealth Policy Center. You're listening to the Commonwealth Matters. I'm here with Bob Moffit, and we're talking about Certificate of Need reform. Bob, I want to bring this back to the Commonwealth of Kentucky. So in Kentucky, there are 18 devices and services, including acute hospital beds, magnetic resonance imaging or MRIs, positron emission tomography or PET scanners. Those are just a few of the things that require a certificate of need from the state before a device might be purchased or a service might be offered. So here's my question. Do we have examples in other states of how CON laws have hurt underserved residents in a community by either not providing any of these things, not enough acute hospital beds, not enough MRI or PET scanners? Do we have evidence or studies that show that CON laws have actually hurt particularly those in rural areas, underserved residents in community, which really is a lot of Kentucky?
That's an excellent question. I cannot answer confidently your question now. I do recall there was a study, I think, of the Pennsylvania situation, where Pennsylvania, repealed certificate of need entirely. And there was some question about whether this was a good thing or a bad thing from the standpoint of, consumer access to care and quality care and all that sort of thing. And I'm just, again, it's vague memory, but my recollection was that one of the impacts of the repeal was that there was an expanded access by for minorities. I think it was Black Americans, Black citizens in Pennsylvania. But the thing is, I'm sure that there's research on that, but I am not confident that I can tell you this morning that, we have hard data on that. The only thing I recall is the Pennsylvania case.
Yeah, and that's something I think we need to dig into.
Oh, I think you should. Anytime there's a reduction of access, obviously lower income people often are the ones who suffer the most. I mean, that's common sense, right? I mean, that's just common sense.
Yeah. So, Bob, I mentioned that the Kentucky Hospital Association is very much opposed to eliminating certificate of need. They've said that it's essential, CON laws are essential to the structure of healthcare in Kentucky. They have said they favor looser restrictions, but they want to maintain it. They point out that 80% of Kentucky's patients are covered by some form of government insurance, and that they need revenue from elective surgeries and other things, leaving Medicaid and Medicare to really pay for a lot of the hospital bills. And they're making, if I understand this correctly, they're making the case that they need certificate of need in place to help maintain this structure to support rural hospitals.
Yeah, well, if you've got a monopoly, yeah, right, okay, fine. If you've got a monopoly, that's great. You've got absolute control over the market. If you've got an oligopoly, you and a small group of people have domination over the market. That's a great thing. It has just absolutely nothing whatsoever to do with the welfare of consumers. Competition, is something that will drive healthcare costs down. And by the way, in 2021, the New England Journal of Medicine published a wonderful article on this whole question. And they found out that where you have consolidated hospital markets, in other words, where, and by the way, most American hospital markets are consolidated, right? The Federal Trade Commission said that 90% of America's hospital markets are consolidated markets. All right, so you don't have competition, and where you don't have competition, you don't have choice. Likewise, if you don't have choice, you don't have competition. It's the different sides of the same coin. But the point is that they've got a good thing going, and there's no question that competition will in fact force efficiencies that do not otherwise exist. they often make an argument that when we have these large organizations and we can have a better consolidation or coordination of care, with these large organizations. I mean, it sounds very attractive, and we'll have economies of scale. And that's where we'll start to make money because, if you pull everything together, you'll have economies of scale. Well, okay, fine. But the data doesn't show that, Richard. The data does not show that. And that's why the Federal Trade Commission and the Department of Justice, under both Democratic and Republican administrations, have said consistently that these things are barriers to entry, they're anti-competitive, and they do not control costs.
Bob, to your point, I'm looking at a few statistics here that regarding certificate of need states. So, for example, CON states have fewer hospital beds. CO states have fewer MRI machines. CON states do not have increased healthcare access for the poor. So those are three major points to consider where it's really not helped more access, more medical resources, more hospital beds. It's really not helped in those areas. And that I really think that supports your point that it's a barrier to access into a community. It has really kept resources away from people who need it most. And this is something, now I'm going to go to a committee hearing in Kentucky earlier in the year where this came up, certificate of need reform came up. There's a bill that proposed to eliminate it in Kentucky. And in this committee hearing, many Republicans who identified as free market said, hey, I can't support this. I'm free market in principle, but I can't support this because it could hurt our local hospital. Now, this issue, by the way, is coming up again on June the 20th. There's another committee hearing. We're in an interim period right now, but another committee hearing is coming up on the 20th, and they're going to discuss this again. And we'll see if any minds are changed. But what would you say to those legislators? And I think if they were just listening in on this conversation, that might be enough. But how do you convince a state representative or a state senator that has a small rural hospital, and that hospital administrator is telling them, "Hey, don't be in favor of this bill because it's going to hurt our bottom line, and we could go out of business"?
In many cases, here's the point. I don't know Kentucky, and I can't speak with authority on your local rural hospitals. What do I know? Okay, I'm here in Washington, D.C. I was very familiar with the hospital markets in Maryland because I had regulatory authority myself over them as chairman of the Maryland Healthcare Commission. But I can tell you this, that most of the time when you're talking about a small rural hospital, what you're really talking about is a hospital that is part of a larger corporate entity. All right. So Kaiser family, the Kaiser Permanente often has hospitals. You have large corporations that have hospitals, and they buy them up, and in the meantime, oftentimes these hospitals will start buying up private independent medical practices, which, by the way, is destroying independent medical practice in this country. And that's another crisis that ought to be addressed by the state legislatures if they get enough brains and guts to take it on. The point is that they will always say, you got to take care of our rural hospitals. You can take care of the rural hospitals, but it doesn't mean that you have to destroy competition for the consumers. I mean, what I'm saying is treat everybody fairly. And if you have a level playing field, where, possibly a very advanced, clinic can provide an MRI just as well with just as well as a hospital, well then, let the 100 flowers bloom. Let people make that choice. I would say this, one thing you could do, and I think, we tried to do this in Maryland, and I think we were somewhat successful, is to be very, very, very rigorous on reporting on the quality and the performance of these hospitals, so people understand, what are medical outcomes like in these hospitals? How are they actually doing? They will always tell you they're doing great. They always say that. But in fact, if you actually do the kind of rigorous testing, just simply because a hospital has a big name, like, I don't want to get into personalities or anything, but Just because a hospital has a big name doesn't necessarily mean that people are getting the best quality care from that hospital. Sometimes you'd be surprised. In Maryland, we did an evaluation of all 48 hospitals, and we were surprised that some of the hospitals that were not highly visible actually had ended up, in terms of actual outcomes, for patients, having A+ ratings. And we didn't know that. But when we published it, what we found is that a lot of other hospitals realized they had to do better, especially on things like emergency cardiac surgery and things of that sort. So, let the people make the decision. What the politicians are really saying, in effect, when they say, "Oh, I've got to protect, an oligopoly," and it's an oligopoly, all right. These rural hospitals, once again, they're often part of a larger hospital system. The job is not to protect the bottom line of private interests. When you're elected to a state legislature, your job is to serve the people. And it should, and your decisions in matters like this should be based on the data. And the economic data, with regard to certificate of need, that data is indisputable. The Federal Trade Commission, under Democratic and Republican administrations, has consistently held that certificate of need laws in the states are barriers to competition. They limit consumer choice, and they stifle innovation.
That's good. Bob, this is to your point earlier about large healthcare systems, often recognizable names, big names in the healthcare industry. We've seen this in Kentucky, where they are buying up local practices. They're expanding in an area. And you had mentioned that this destroys the independent medical providers. And it's really essentially what I'm hearing in this, and what I think should be obvious, is that competition is being stifled. When you become part of a larger organization, and not necessarily that larger's bad, but you are taking away competition in the healthcare industry. And we're seeing this in Kentucky. There's a news story recently about University of Kentucky healthcare system purchasing a number of clinics and I think hospitals in the eastern part of the state. Major move to expand into other parts of the state. And this essentially does remove competition, because these other clinics and hospitals are coming under the umbrella, along with the rules and procedures. They're really working for one organization, instead of having several smaller organizations that are competing and offering things that really give a choice to patients. Isn't that the case?
Exactly. Well, mergers and acquisitions in hospitals have been going on for quite some time now. Actually, the biggest expansion of mergers and acquisitions in hospitals took place before 2000, before the turn of the century. But during the Obama years, with the passage of the Affordable Care Act, you had a massive increase in federal regulation over the healthcare delivery system. And that encouraged even further consolidation of hospitals. In fact, between 2013 and 2017 alone, there were something like, I've got the numbers here, 456 mergers. In 2018 alone, there were 90 mergers. So what happened when you increase government regulation, the smaller people can't deal with the transactional costs, the time, the energy, and the effort to comply with these regulations. So often what they'll do is they'll join up with a larger organization that can absorb the paperwork costs, the administrative costs of the regulatory, the consequence of the regulatory excesses. And so that's the way it normally works. We've got to stop this, because the big problem is that independent medical practice, the doctor-patient relationship, which is really critical. It's crucial. It should be the basis of our healthcare reform efforts to restore the traditional doctor-patient relationship. That is being weakened by these economic and regulatory changes that are basically being driven by government policy.
Bob, I would love to talk further. That's a whole new program, fascinating topic, and unfortunately, we're out of time for this program. Would you come back and talk further about the doctor-patient relationship and offering more choices and reducing costs to patients? But I think that's a whole nother conversation. But man, I've really enjoyed this with you. Again, Bob Moffit, thank you so much for sharing your insight and wisdom regarding Certificate of Need reform. And thank you all for tuning into the Commonwealth Matters. If you could, go to your favorite podcast platform and rate us and tell your friends about the Commonwealth Matters and encourage them to tune in as well. Thank you, and may God bless you.